So good evening and welcome to everyone. Before we begin, I'd like to take a moment to respectfully acknowledge the traditional ceded and unceded territories of the Indigenous peoples across Turtle Island and in the land that the colonizing peoples now call Canada. We're deeply grateful to live, work, and learn on these lands, which have been cared for by Indigenous peoples for thousands of years. We honor the lasting connection between Indigenous peoples and their traditional territories. We recognize the importance of learning from, respecting, and amplifying the histories, cultures, and contributions of all Indigenous peoples. And we humbly acknowledge the need to work towards restoring meaningful, honorable relationships with them, which includes advocating for the co-creation of culturally safe healthcare systems, the closing of any healthcare gaps between Indigenous and non-Indigenous peoples, and the embedding of Indigenous wellness into all aspects of kidney healthcare. My name is Michelle Lynn Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, awareness, and advocacy, and education and support. Our topic tonight is one that's been popular. I get a lot of questions from people in our community about this. It's genetic testing for polycystic kidney disease. And we know that genetic counseling could play an important role, but we want to really understand when are the times that we need to ask for or expect to have genetic testing, and when are the times when it might not be necessary. At our roundtable tonight, we have Dr. Matt Lanktree, nephrologist, and Nick Ashawasega, an ADPKD patient, and we'll explore the basics of genetic counseling and testing for PKD. This webinar is being recorded, and it will be available to view on our YouTube channel in the coming weeks. And tonight's presentation will be a collaborative roundtable with plenty of time to ask questions. So feel free to either leave your questions in the Q&A area or in the chat. And throughout the presentation, I'll be checking in to see if there are any questions that relate to what we're talking at the moment. We don't necessarily have to wait until the very end, although we can also, we'll have probably a bit of time to answer questions at the end as well. So now I'll introduce our panelists this evening. Dr. Matt Lanktree is a clinician-scientist, associate professor, and medical director of the McMaster Kidney Genetics Clinic. Matt has published over 100 articles in genetics and medicine with ongoing studies into genetics and CKD. Matt cares for hundreds of patients with ADPKD, as well as patients with many other inherited kinds of kidney disease, and he has set his goal to use genetics to improve the care of patients with kidney disease. Nick Ashawasega is a PKD patient whose ADPKD story was shared by Patient Voice in 2023. He's been involved as a patient partner in the Canadian review of the 2025 KDIGO ADPKD guideline, and he has a passion for improving PKD diagnosis and care in Indigenous communities. So welcome, Matt and Nick.
Thank you.
You're welcome.
Thank you, guys. Appreciate the time.
So we're going to start out. Matt, I'm going to ask you just some basic questions about how PKD is inherited. And we'll start with ADPKD, or autosomal dominant PKD. How is that passed from parent to child?
Well, first off, I want to say again, thank you so much for having me, and for the PKD Foundation of Canada, really for creating these opportunities for education, and for everybody who's joined us. Thank you for giving your time this evening. I hope this roundtable format that's a little bit more conversational is accessible and really proves valuable for everybody here. As for autosomal dominant polycystic kidney disease, so autosomal dominant means that all of us have two copies of our genes, one from our mom and one from our dad. If it's autosomal dominant, only one of those two copies of the gene needs to have an issue with it to lead to the phenotype. So autosomal dominant, they don't skip generations. there should be an affected person at every generation of the family. Only one of the two copies of the gene needs to have the problem to cause the disease.
Okay. Sorry, I'm trying to juggle too many balls here. Um, are there a number of different genes that can cause ADPKD or
Uh,
lead to the disease?
Absolutely. So ADPKD is most commonly caused by in about two-thirds of patients due to a genetic change in polycystin 1 or PKD1. About a third have a change in polycystin 2 or PKD2. About 10% of people with ADPKD have a genetic change not in PKD1 or PKD2. Now, there's a growing list of additional genes, 10, 20 additional, but all of those account for only one, two, cumulatively maybe 5% at the high side. So the vast majority, about two-thirds are due to PKD1, about one-third are due to PKD2, and then there's a list of other genes that can contribute. Now, that said, so the next question is, well, how much of a difference does it make which gene is impacted? Certainly, the people with PKD1 on average have a more severe disease. So oftentimes their kidneys look more like a bag full of marbles, lots of cysts. They have more rapid progression of the disease, so that GFR number can decline a little bit faster over time, usually in the 5 to 7 mils per minute per year, so that GFR number. And the average age at kidney failure may be about 50, 55, like in the fifth generation of life. People with PKD2 variants on average have fewer cysts that are larger in volume, but the rate of decline is usually a little bit slower, with the mean age at kidney failure into the seventh decade of life. Now, people with the other forms, so I said, up to 20 other genes can account for a small percentage of people. On average, those people have milder kidney disease. They can have other ramifications, on other organs, particularly the liver, but in general, they have milder disease, those non-PKD1, non-PKD2 forms of polycystic kidney disease. Now, that said, it's important to remember that genetics are not deterministic. So while they can help us identify what disease a person has, there's still lots of variability. And we can see that even in family members who have the same cause of their disease. So two siblings, say, that both have cysts in their kidneys are going to have the same familial genetic change that led to the disease. Yet we've seen in some families, so while, most families, the age at kidney failure is pretty similar between family members, there are situations where there's discordance, there's big gaps. One brother is much more affected than the other brother. And so we know there's more that contributes to your disease severity than just that main effect, genetic change. And that really provides hope and opportunity because we want to make sure we do everything we can to make sure your disease is as mild as it can be for the given genetic change that led to the cysts in the first place.
Thank you. And do you think it's important um, for the for any PKD patient to know which type of PKD they have or not?
Yeah, so I mean, this has been honestly hotly debated over, the last even 20 years. 20 years ago, we started genetic testing was very difficult and complicated, and over time, our ability to do genetic testing for these genes has gotten better and better, and subsequently, it's gotten more cost effective. That said, as I said, there could be a lot of variability even in two people that have the same genetic variant. And so, if you're talking about disease severity, it's more important that we take into account all of the factors. So, like the size of the kidney function, that GFR number for your given age, other biomarkers, potentially whether there's protein in the urine. So, there's a lot that needs to go into what we call risk stratification or determining how severe an individual is affected that goes beyond genetic testing. There was many years there where particularly nephrologists in the United States said the imaging is all, if we know if it walks like a duck, it quacks like a duck, it's probably a duck, and we can assess their disease severity best with imaging. So we probably don't need genetic testing. You know, in contrast, there was a score called the Pro PKD score, which came out of Europe, that didn't include imaging because MRI wasn't often done in Europe. And so that Pro PKD score was based on high blood pressure, having blood in the P or urologic complications, as well as the genetic variant. So, there was this kind of battle in the literature, not battle, but I mean conversation between people, whether we needed that genetic information or whether the imaging, especially, when it's a really classic presentation and we're pretty sure we know what we're dealing with, does genetics help that much? Now, you know, it's my opinion that this is a lifelong disease. It affects many members of the same family. Interventions can have side effects and costs and challenges. And of course, like developing kidney failure and kidney transplants and all that. I think it's reasonable that everybody should be tested, or at least family member, someone in the family should be tested at some point in time. And remember that genetic change stays constant throughout life. So as long as we keep the records, that information should be available. Once they've got that information, that family has that information. So I do think it's reasonable that at some point, uh, each family should know their familial variant. Now, the other side of the coin is that it's not necessarily an urgency, and when should we do that testing? And so there are complications. And then on top of that, within different jurisdictions, unfortunately, the reality is there's still some variability in access. So, even across different provinces in Canada, but then even within the same province, depending on who the providers are and where you're located, there may not be the expertise or the easy access to the testing. Certainly that's across Canada. And then if there's international viewers, it becomes even more complicated from place to place. So, I wouldn't say it's absolutely necessary, especially in circumstances where the provider, and certainly I'm not providing health advice in the way that like every individual should talk to their physician, given their circumstance, their family history, their disease severity, and all those when they're making the decision on whether they should get genetic testing or not. But the reality is the cost of the testing is dropping. It's good information for the family, for cascade screening, for making sure that indeed it is a duck. Like I said, walks like a duck, quacks like a duck. It's probably a duck, but let's be sure it's a duck. And um, yeah,
Awesome. Thanks so much. I see there's already been a couple of questions come in. Someone in the chat is saying, and I've taken the liberty of answering this, but you can tell me if I've done it properly. With 3 kids, what is the mathematical likelihood of one of them inheriting ADPKD from me? And I've answered, each child has a 50% chance of having ADPKD, and all 3 of them could inherit it, or none of them, but it's that 50% chance every time.
that's right. So it's just like flipping a coin, and it's like saying if I flip the coin 3 times, what is the likelihood that I will ever get a head, right? Or ever get a tail. So, um, yeah. So it is the chance of not having one is a half times a half times a half, which is an eighth, right? So that'd be the likelihood of having no child.
And someone else has contributed that her aunt had ADPKD and none of her four children had it, but this person's mother did have ADPKD as well, and two of her three daughters had ADPKD. So it really can, it's just that tossed every time the new embryo is made, you know.
So there's a little bit of a question there. So regardless of so PKD1 and PKD2 are both what we call autosomal. So they're on non-sex chromosomes. So they're independent. You don't have families where some people are PKD1 and some people are PKD2. The family has the same variant. And they're both 50-50 of being passed on. So it's not like PKD1 passes on more often. They're both 50-50. And indeed, for most of the other, rarer genetic causes, the vast majority of them are also autosomal dominant. There are some, though, that are not. Yeah.
Okay. There's another question here that's in the Q&A. And that I'm not sure if that was the one you were trying to address, but
Well, and I can say, yeah, so like it says, sorry to interrupt here. So it says, so we
yeah,
have PKD type 1, right? Well, you can't tell that just based
yeah,
on family history because either
right,
PKD1 or 2 have the same inheritance. Absolutely.
right, right. Awesome. Now I see there is another question in the chat about what age should children be tested, but I know we're going to talk about some scenarios a little bit later in this roundtable, so I'll save that one for then. And I think the next one too. So, Nick, if you'd like to move on to the next question for Dr. Matt.
Wonderful. I believe we're on question 4 there, right? Just to confirm there with you, Michelle, before I ask the wrong question. But you know what? If it is, we can cover the other one.
Sure.
So I
No, go ahead.
believe we had, is PKD always inherited or can it sometimes happen spontaneously?
So I talked about 2/3 is PKD1, a third is PKD2 approximately, and then, up to 10%. So there's 5 to 10% of individuals have PKD without an affected parent. So they say no apparent family history. So it's as common that people with no apparent family history, their parents may have passed away of something else before it was discovered that they had it. So say someone passes away of a heart attack at age 50 and it wasn't recognized they had chronic kidney disease or cysts on their kidneys. So it's possible prior generations are affected and it just wasn't known. Obviously, situations of like non-paternity or adoption or things like that, unknown family history also account for some of the individuals with no prior generations. Um, so it is possible for a new mutation. I hesitate to use the word mutation because patients have told us that, we hear mutation and we think of like X-Men and we think that there's, something inherently wrong with us or that we're a mutant or that, and it really comes with a negative connotation, a negative feeling. And so, patient groups have explained it was really driven by the American College of Medical Genetics when they surveyed patients about it, and they prefer genetic changes to be referred to as variants or variations, and then putting labels on the variant. So if it's likely pathogenic or pathogenic variant. Now, the problem is that it sounds like a bit of a mouthful too, in a way, calling it like a pathogenic variant. People say, well, what does that mean? So, um, the reality is, though, that some people, while they develop, can develop these pathogenic variants or this mutation as they're developing. Now, if that happens, if it happened very early, say right during when fertilization, when the sperm and egg joined, if it's that early, then all of the cells can carry that new pathogenic change. In contrast, if it happens during development, it's possible that the cells have different genetics within one person. So that situation is called mosaicism or a mosaic because you have different genotypes and different cells in your body. So PKD, both PKD1, 2, and the other causes typically impact both kidneys equally. And so the cyst should be in both sides. Now, if you get one of these situations where it's a mutation that happened later in development, it's possible that you can have one kidney impacted and the other kidney not impacted. So again, this is unusual situations, but things that we do come across as you take care of lots of patients. So it's possible that there's a new genetic change that leads to disease in an individual that didn't have a prior history of ADPKD, but it's an unusual situation. And frankly, it's more common that people just didn't know the prior generations are impacted. And I even still see patients now who are referred to me in their 40s, and I say, well, how are your parents doing? And they say, oh, my dad's 68 and he refuses to see a doctor. I mean, we don't necessarily know that that person doesn't have chronic kidney disease if they've never been screened and never seen a doctor. And so that's why it's important that we differentiate unknown from no family history, right?
Right. And it's kind of related to that. I see someone's asked in the chat, can the gene skip a generation?
So in AD, autosomal dominant polycystic kidney disease, so these ones that we've been talking to due to PKD 1, 2, and this other group, it cannot skip generations. So if a person doesn't have it, then their kids cannot have it because it's a dominant condition. If either one of those had it, they would. So it does not, that's one of the features of autosomal dominant. So again, there are some weird and wonderful, so we can get off the beaten track that there can be unusual situations. But as a rule, I would say no, it does not skip generations.
Awesome. Well, thanks for sort of clarifying the different ways that it can be inherited and the different types of PKD, ADPKD. Why don't we start talking about some cases where you would recommend that someone in the family get some genetic testing? Nick, would you like to talk about the first possible scenario?
Yes, wonderful. So for you, Dr. Lanktree, a 29-year-old woman has a few cysts on each kidney found during a scan for back pain. Her kidney function is normal, and her doctor isn't sure if the findings meet PKD criteria. The question is, how would you assess whether this patient should have genetic testing to clarify the diagnosis?
So the first thing I would say is this kidney function is normal. So how we've estimated kidney function is typically with this estimated glomerular filtration rate, which is a mouthful, but eGFR, which is estimated from creatinine. So creatinine is a breakdown product of our muscles. It's water-soluble waste that goes out in our pee. If our pee is not clearing it as well, then the creatinine builds up and that eGFR goes down. Now, we take it for granted, but actually, eGFR is relatively new and continues to change. There were just changes in the estimating equations in 2021. So, the estimation of kidney function, particularly in the normal range, is still continuing to improve. So, years ago, the teaching was that kidney function was totally normal until it fell off a cliff and you had kidney failure. And the cysts would go throughout life, but the kidneys worked fine until they didn't work. Since we're getting better at estimating kidney function, we now know that there's actually a decline that's fairly linear and predictable throughout life. So, it's important that if you have a 29-year-old, that GFR number, if it's 65, like some labs would report greater than 60 as normal. Some will report greater than 90 as normal. But so that GFR of 75 in a 29-year-old isn't normal, even though it's not in the like CKD range or like where people would raise alarms of having kidney disease. So when my residents come to clinic, I say, don't tell me the kidney function is normal. Tell me that eGFR number. Now, that said, the eGFR goes up and down like the stock market. I mean, there could be 15, 20% variability in GFR from measurement to measurement. So we can't get too excited with just one measurement, but we really need to track that GFR change over time. Okay. Now, the first question with this person with cysts in their kidney, and we're going to delve into whether that kidney function is normal or not. The next question, and the next thing that I didn't talk about yet, but I think something to think about is, well, if it's not PKD1, what is it? Right? So, having cysts on your kidney is actually not that uncommon. And we continue to get them throughout life, so that many people, by the time they're 50, will have a cyst on their kidney. So these may come from kidney stones or periods when there was a blockage in the tubule, times where you've been sick or unwell. So, and frankly, for reasons that we don't understand, they're just called simple cysts. So one cyst is not uncommon. Having a couple cysts is also not that uncommon, which is why if you look at the ultrasound-based criteria that they use to look at, you want more cysts, especially as you're getting older in life, and you should have both kidneys with cysts in them. Now, on top of that, the criteria that were developed, they're called the Ravine-Pay criteria, named after Dr. Pay in Toronto, who came up with them, but they were based on having a positive family history of disease. Because if you have the disease in the prior generation, we just talked about the likelihood of you having it is 50-50 to begin with. Whereas people just in the general population, the likelihood of them having PKD, if their parents didn't have PKD, is actually very unlikely, right? It's below the population prevalence of the disease, which is about 1 in 1,000. So the criteria for using imaging to figure out whether this person has PKD or not is heavily dependent on having a family history. Okay? So now that said, no primary care provider is going to be comfortable ordering genetic testing, nor should they, for polycystic kidney disease. If there's concern about it, then they're going to have to be referred to a nephrologist to weigh the pros and cons in looking at it. If there's no family history and there's multiple cysts in the kidney, especially if there's a decline in kidney function, that would be the situation where genetic testing can be the most helpful. Now, the challenge in that situation is that it can also have the most ramifications for patients. So, I really counsel people when they come to me asking for genetic testing for their disease. So the first thing, you need to consider whether you have critical illness insurance, life insurance, drug and disability insurance, and what your availability to those kind of options are. We have in Canada a Genetic Non-Discrimination Act, so nobody can force you to provide the results of genetic testing. Your genetic testing results are between you and your physician. So no insurance company, no employer can make you provide the results of genetic testing. However, your medical history and your family history are not protected by the Genetic Non-Discrimination Act. Meaning that if you apply for life insurance, a type of life insurance that requires a medical, and they have access to your medical records, then if you have a diagnosis of polycystic kidney disease, regardless of whether it was come to through a genetic test or not, that information is not protected and would need to be provided. Similarly, if you have a family, so if your parent has cysts on their kidney or developed kidney failure, the insurance companies can ask for that information. If you don't provide the information, you could end up paying payments throughout your life for that kind of, and then when you come to collect on it, they say, aha, but you never provided us the information that you needed to provide, and they could try to deny payment of the claim. So it's never wise to try to hide anything from an insurance company, because in the end, they're always going to win. So that does mean, though, for an individual who has no family history, you could go from having some cysts on your kidney to having a diagnosis of autosomal dominant polycystic kidney disease on the basis of genetic testing. So I do think it's wise to try to line up those kinds of insurances before delving down into whether you have the disease or not. That's the reality of the situation. So certainly, if you have multiple cysts, especially on both kidneys, and if you have no family history of disease, then genetic testing can be particularly helpful, but it may also have the most ramifications on like insurability.
And you make a good point. I know that I had been planning at some point in today's roundtable to talk about those implications, but you shared that very well. We have another scenario that's kind of similar. If a 42-year-old man has multiple cysts on both kidneys, but no known relatives with PKD, could it be PKD or another type of cystic disease? And assuming that they already have all of their insurance needs taken care of, when would you think it might be valuable to know, yes, it's PKD and not another type of cystic disease?
So off the bat, I want to say I'm not a pediatrician. I take care of adults with PKD. That said, PKD is a heritable condition, and I'm often dealing with parents that are with the disease who have children potentially affected by the disease. So again, any of this should be discussed with your pediatrician. I'm not, I don't want to give specific advice. Now, it is important with children that are at the potential of having ADPKD that screening for any complications of PKD, is reasonable. So usually the first signs would be high blood pressure, potentially having blood in the pee, very less likely potentially with flank pain or something like that. So certainly screening like that. So we talked about whether genetic testing and there's concerns about insurability, but if the parents are affected, then even if they apply for any kind of insurance, the positive family history is probably going to be a strike against. And if anything, there's situations where genetic testing can suggest that the child does not have the familial variant and could make them a candidate for insurance. That said, I do think there can be a large, and Nick can speak to this, I'm sure, there can be a psychological baggage associated with knowing that you have a genetic disease. I believe that people should be able to meet all of their goals and all their, there shouldn't be any, you know, dissuasion from following a profession or frankly, participating in any activity. And so, the relative benefits of genetic testing need to be weighed for each parent and for each child. I mean, I think ideally the child should be participating in the discussion and the decision. Certainly that's going to be hard in 5-year-olds or 8-year-olds, but as they approach teenagers, I suspect they're able to comprehend and participate in the discussion and the decision on whether to do it or not. I think yeah, they can live their life like they just don't have it until it becomes a problem. The reality is, if there is no manifestations of the disease, there's no need for early intervention. So any of the treatments we provide for slowing progression of disease haven't been approved in pediatric cases. So there isn't a need for disease prevention or treatment in the pediatric age set for ADPKD unless it's a really different, more severe form of the disease. But again, you would be better served by a pediatric nephrologist talking about those situations.
For sure. And I'll let the people who are attending live know that we do have one of our pediatric PKD experts, Dr. Lisa Gay Woodford, will be giving us one of her annual webinars towards the end of November. So questions about ARPKD and childhood ADPKD can be can be kept unanswered till then. Nick, I wondered if right now might be, if you feel comfortable sharing, what your own experience was getting diagnosed.
No, yeah, definitely. As Dr. Langtree covered a little bit there. And also, thank you, Sarah, for the compliment on the radio voice. Much appreciated. I will bother my wife with that, as I like to bother her with all compliments about my voice, because she's heard it for almost 15 years now, so it doesn't have the same effect on her. But so yeah, my journey with PKD has actually started when I was 5 years old. I was diagnosed as one of those kids in the early 90s by a family doctor, thankfully, who obviously saw something and instead of just brushing it off, realized that there was something more here. So yeah, 5 years old, I woke up with blood in my urine, and my mother was very concerned, obviously. I'd also had like asthma and things like that. So definitely, a little bit of a sick kid. So when they took me in, they were very concerned. They weren't sure what it was. And after a few different tests, finally the ultrasound is what, kicked off everything. And there was cysts. But yeah, for me, none of my family had actually been diagnosed up until me. So I had many uncles and aunts who had just been living their life with PKD, and for better or worse. A lot of dots were connected. A lot of our family had been on dialysis, and their kidney function had been declining just, when they hit their late 30s, 40s, into their 50s. For myself, I haven't actually had genetic testing either, which I'm looking forward to getting done in the future to figure out, because I know my childhood was definitely very affected by it. And I know if my mother was able to have a little bit more information around what type of ADPKD we have, it definitely would have helped, I think, in certain scenarios. But at the end of the day, I look at like genetic testing as this is planning for the now, and something like worrying about the insurance costs and that kind of stuff around, payouts for, deaths or anything like that is worrying about what might happen. So definitely find the balance there as you were talking, Dr. Langtree. But I know for myself, having more access to information has allowed me to be far less worried about my own children who are 10 and 6 having ADPKD potentially. We haven't even been worried about getting them tested yet. But yeah, so for me, I've been able to do a lot, but I can wholeheartedly admit I've dealt with depression, PTSD, a lot of various mental health issues from a young age. And I know my PKD diagnosis was a big part of that. Also, they just didn't have a lot of information. I was one of those kids who they thought I was going to fall off the cliff and probably be on dialysis and potentially might not live very long into my 20s and 30s, because obviously kidneys are very important. My mother being a bit of a worrywart was not the thing she needed to hear. But yeah, so for me, long story short, I now have an GR that's usually ranges between 85 and 100. So like, thankfully, I'm on Genarc, and I know there's a lot of pros and cons out there and a lot of dialogue around it. I actually know quite a few people who are, against it, but at the same time, I am for it for myself. And as I tell everyone, they're on their own journey. But I think anything you can do, if it is a medication that does work, I think, we've reached the point in our evolution as humans that all the science we can provide ourselves can help, but obviously make sure you have a little bit of self-thought and management around that. But yeah, so my childhood journey was a long one and involved a lot of ups and downs. Thankfully, sick kids, though, when I was able to get in with them, they were really great. Into my future, I met Dr. Tobe, and of course now I have one of the greatest, kidney doctors I think out there in Dr. Langtree. So I should say also, I'm very biased, everyone. I am one of his adult PKD patients as well. So, but yeah, it's a tough one psychologically for sure. Like I remember not playing certain sports like hockey because my mom said I couldn't, whereas as soon as I did this study with Dr. Langtree and talked to some of the doctors, my favorite story now is there's a doctor in Montreal. He's like, I have a patient who's been doing MMA his whole life. Like, yeah, he's burst some cysts, but it's like I remember growing up thinking a burst cyst was they thought it would be, infection and death potentially. So don't even take the risk. Whereas now, we've learned that it's not the end of the world. Obviously, if you can prevent that stuff, do it. But you can live your life, as Dr. Langtree said, and why not have more information to maybe manage things as they come along in that life?
So thanks so much for sharing your story, Nick. I know that hearing hearing from patients, especially having that kind of dual experience of having been a child with PKD and then now having children of your own, people can really relate to that. I know I'm going to jump ahead a little bit to some of the scenarios we had thought about sharing. I know there's been a lot of questions, even in the chat, about parents who know they have PKD and are wondering when and why to get children tested. And I know you've covered some of that already, Matt, but
I think
is there
it really comes down to the best situation is that the child, you know, the parent needs to think about when this needs to be broached, that it is a possibility. And I think having the child participate in the conversation is the most important thing. Now, that said, if there are, manifestations of the disease early, well, then the testing is going to be done more, expediently. Maybe not urgently, but at a younger age. If the child is happy, healthy, growing, their blood pressure is great, then I think there's no harm in delaying diagnosis a little bit. Now that said, this is still opinion, and frankly, I don't know if we'll ever have a concrete answer to what is best. It's going to be best for each parent and each child and each situation. There have been guideline documents by both like KDIGO, which is Kidney Disease Improving Global Outcomes, as well as like the UK Renal Group has specifically written on this topic of when to get children tested. So it is a little bit, again, it needs to be targeted specifically for each family. But if there aren't any problems and the child's doing well, then I think you can wait a little bit until the child is ready to participate in the discussion. Hopefully, even if they do receive, so like diagnosing asymptomatic people with a genetic disease, my concern with that is it leads people to, unnecessarily change their life plans. And so, what if it is positive or it is negative? If you're completely asymptomatic, why shake that tree, Um, that's my personal viewpoint on it.
Mhm.
Now, that said, if
And
they're not asymptomatic, then the situation is there to do the testing, right?
for sure, I know, and we often hear, I hear from patients all the time who are calling us or emailing us, or commenting on social media, and I get both sides. I get some people who found out when they were young and they say it ruined their life. They felt like they didn't have the childhood they wanted to have because now they knew they had this disease. And then there are others who, knowing is for them kind of a power. You know,
For
I've got
sure.
this thing and now I can, be as proactive as I can. But
Half the
uh,
time they may come back negative, in which
yeah,
case then they say like, oh, then I don't need to worry about it anymore.
yeah.
And there is an argument to that for sure. But I do see someone here has said, can we define symptomatic? But I mean, again, certainly it would be concerns of flank pain, concerns of blood pressure or blood in the pee. All those would be really signs to go through. Is hypertension or blood and protein in the urine? Yeah, those generally speaking, early on, those are the only symptoms. And certainly, like the flank pain becomes more of an issue as the kidneys grow in large, which usually is into the 20s or 30s, like later into life. Um, yeah,
Okay, great. I have one more question. This is from one of our registrants. People occasionally we give them the opportunity to ask questions ahead of an event, and someone has asked, what about with adult children? And how do you then, obviously, adult children are no longer under their parents' care, but how does a family have a conversation about that?
for
And
sure.
what, yeah.
So in contrast to children where we don't have any interventions for people with asymptomatic disease, we do have interventions to slow progression once people are into the adult range. So that's when screening starts to make sense. And then we need to go beyond genetics, even with imaging, to make sure that we really assess the disease severity in the individual. Because there's lots of people, about half, that we can reassure that your disease is relatively mild and we can just do the things that I tell everybody to do, whether they have kidney disease or not. You know, be fit, lean, active, manage blood control, don't smoke, don't drink too much, you know, like all those kind of good things that all of us know we should be doing. But certainly, you know, assessing, especially those on the more severe side, is there more that we can be doing before the proverbial horse is out of the barn, right? Before the cysts have grown to the point and the kidneys are to the point that we can't help it anymore. Unfortunately, PKD and kidney disease in general, we can slow progression, but we can't turn it around and make it go away. There's no cure. It's just keeping what we have for as long as possible. I see one viewer mentioned about like, what if having a diagnosis leads to better choices? I mean, the reality is we should all make good choices no matter what. So whether, you know, there's no secret diet, you know, that's going to make this problem go away. People who do have more severe disease, it's not because they made bad decisions, you know, like we really need, all of us need to make the best choices we can. We need to be as fit, lean, and active as we can, follow the Canada food guidelines. You know, being reasonable, healthy, making good health decisions is good no matter what.
Um, it seems like I think we've kind of answered a lot of when should children of known PKD in the family get tested. I'm going to go back to scenario 4 for Matt and Nick. Family planning decisions. So you are you are thinking of having a family. You know either that you do have it, or maybe you don't know. You know it's in your family, but you haven't been tested yourself. What is the value, or what are the things to think about when you're trying to plan for a family and you know that there's a ADPKD in the family?
For sure. So preconception counseling, I think, is an area of need in Canada that we need to do a better job, both for PKD, but all genetic diseases. Um, there is, so, you know, if we conceive the normal way. As we said, it's a 50-50 that the children will be affected. On one hand, you know, usually the children have similar disease severity to the parents. And for millennia, there have been parents with PKD that have had children, right? So it doesn't impact fertility to a large extent, anyways, perhaps to a small extent, but certainly lots of people with PKD, both men and women, have parents children successfully. And you know, down the line, maybe we'll have more therapies and treatments if your child is affected. If you want to avoid having a child impacted by polycystic kidney disease, theoretically, there is the option for what's called preconception testing, or so you can do in vitro fertilization and pre-implantation genetic diagnostics. So in that case, the woman would go for egg retrieval. The fertilization from the partner happens in vitro. They then test the cells uh, that they do not carry the pathogenic variant from the parent, and then only do embryo transfer for embryos that are not impacted. They only transfer the embryos that are not impacted by the pathogenic change. There is, so again, the coverage for this varies from province to province. It is not complete. I'm not familiar with all the ins and outs of all the provinces. Within Ontario, it is partially covered, but it is still expensive. So it is possible. I have a couple patients that have been referred for it. I do have some patients even that have had children in both ways. So that's where that is.
Yep. And I want to let, again, all the people who are attending live know that we have one of our summit sessions in November is on exactly that, on genetic counseling for ADPKD. And we will have an OBGYN taught who works in fertility talking about all of the different options for having children, including the IVF and the pre-implantation genetic testing. And when I send out I usually send out a post-event email to all of the attendees and all of the registrants. I will include information about those as well. Just going to check because I see that there's another question. Oh,
I do see a question about genetic testing in Ontario. Again, for viewers, I'm not sure of every jurisdiction within Ontario in the context of essentially there's an appropriate question for genetic testing for PKD. It is covered by the Ministry of Health. If there's a provider who's familiar with ordering and interpretation of the tests. So certainly if you're seeing a nephrologist who's unable to do that, some aren't able to, they may require a referral. Certainly if it's in Ontario, you could be referred to me and we could even do it virtually if you're not local to Hamilton. That's where I'm located. There are others across other centers of excellence across Ontario that can provide this kind of testing as well.
awesome. I'd like to ask one more scenario before we get into some of the costs and or some of the how to get a test done. If a sibling of someone wants to donate their kidney to a sibling or a mother or father who they know have PKD and need a living donor, want a living kidney donation. What is the scenario for testing that?
So the recommendation is to test the recipient. So the person who has kidney failure, is approaching kidney failure, who's looking for a transplant, that person should be tested to identify the familial variant. If there's a living related potential donor who would be giving to the recipient, you can then test the donor for the familial variant that led to their relative's kidney failure. So that's called cascade screening. Similarly, we can cascade screen people at any age to try to determine if you have the familial variant of people who are impacted by the disease. So typically we test the recipient and then do cascade testing of the potential donors for that familial variant. And the reason we go in that direction is if we just tested the donor, you can end up with these, they're called variants of uncertain significance. So all of us have lots of changes in our DNA. And sometimes we get these genetic changes that are hard to determine whether they're disease causing or not. And so to try to avoid that problem, we test the recipient first and then test the familial donors for the same variant that the recipient has. The
Awesome.
other thing that can go into that is the age of the donor. I mean, if the recipient's 50 and their older brother who's 55, I mean, in that case, all you need is an ultrasound, because if they're 55, if they would have cysts on their kidney if they have the disease. If they don't have cysts or they have one simple cyst and they're 55, then they don't have the disease and genetic testing is less required. It's really in individuals, especially under the age of 30. If you're considering donating a kidney and you're in your 20s to a sibling, then it's possible that you haven't had time to manifest the disease. So genetic testing is even more important in younger living donors.
Right. Thanks. That makes sense. Someone's asking in the chat, does the referral for genetic testing have to come from the nephrologist? Her adult kids are interested, but they only have, they don't have a primary care physician. They only have walk-in
Adult
access.
kids are best served by just getting an ultrasound, and any walk-in clinic or family doctor can order an ultrasound. If there's any cysts on the kidney, then they should be referred to a nephrologist to assess whether it's appropriate to do genetic testing and what the situation is. But no, the primary care provider wouldn't be ordering or interpreting or genetic testing.
I had another question that came from one of the registrants, and it's an interesting generational thing where the person's father has PKD and the daughter wants to get genetic testing, but they are being told that the father needs to get the genetic test first, and his nephrologist won't give him a genetic test because it won't impact or change his care. So in a situation like that, is there a
Sorry,
way of,
I maybe missed the beginning of it. So the mother's impacted, but
no, the daughter
yes.
wants to know if she has PKD or not, doesn't give an age. The daughter knows that the father has PKD, but not what kind. And so is being
Does the daughter
told,
have cysts on her kidney?
doesn't say.
We, so the first test would be an ultrasound, and if they say there's a family history of kidney cysts, then they should be able to get it. An abdominal ultrasound is very easily accessible, and that's the best screening test. And if their kidney function is normal and there isn't cysts on the kidney, then we're done, right? If in contrast, if there are cysts in the kidney or that EGFR number has any signs of being lower, and then the question is going to be about um, whether there's additional information to be gained from genetic testing. If the father, we don't really know. You said 59, did you say that?
Definitely middle-aged.
If the father's, middle-aged and, the kidney function is still normal, that may be where the nephrologist is like, your kidney function's normal and it's not going to change I don't think you're at a high risk that we don't need to do. Now, that said, if the patient says, but it's going to impact my familial screening, I still really want to know, then, in that situation, I think asking the nephrologist or else for a referral somewhere else would potentially be options. Um, yeah, it's a little bit hard to tell throughout
Yeah,
without details and
yeah.
maybe having that bit of that nuanced conversation. Plus, she only knows what her dad said to the nephrologist. Stuff gets lost in translation or in communication, broken telephone all the time.
Awesome. Thank you so much. Well, I think we've addressed all the issues that people were asking in the chat and the question and answer, even if we didn't speak to their specific question. And we're nearly,
I do
our
see
time is,
one question here, which is kind of
okay,
unrelated to the topic at
okay.
hand, but it was about removal of the kidneys.
Oh, right, yes.
So the short answer is that we want to hold on to any kidney function you have for as long as possible. So if those kidneys are filtering at all, even while on dialysis or even after you get a new transplant, if we can keep your kidneys there, we're better. Now, that said, if you're having recurrent infections or pain, if you're having hematuria or there's concern about a malignancy in it, certainly they may remove one or both of the kidneys. The decision of the timing of when to remove them is a bit of a complicated one. So depending on you may end up being pushed onto dialysis. So the suggestion is we should wait for nephrectomies after the transplant occurs. But sometimes it's felt that a kidney needs to come out in order to make space for the transplanted kidney. So again, it's a bit of a nuanced discussion, but the bottom line is we want to keep our kidneys around as long as we can, unless they're causing problems.
Awesome. Thank you so much. Well, I'd like to thank both of you, Matt and Nick, for being here today and sharing your experience and sharing your thoughts. I know that this has been a really popular topic. We had a lot of registrants, and I'd like to let people know that if you have any questions that you feel weren't answered today, drop them. There'll be a little survey as you exit the screen, and drop them there or email us, and we can try and get some answers for you or point you in the direction of some resources that we already have. And as well, we have our PKD Summit coming up on November 5th and 6th. and I will include registration links for all of the sessions for that in the follow-up email. But I'll just point out again that we do have one on family planning with PKD, and we also have another one on pregnancy with PKD. So if you are the person with a uterus and you have PKD, what impact that may have on your pregnancy. So thank you again, Dr. Matt and Nick. Sorry, I thought I saw maybe another question. Thank you again, both, for being here, and we really appreciate.
Thank you. My pleasure.
Yes, thank you guys. Appreciate it.
See you
Awesome.
soon, Nick.
Yes, good to see you, Matt.
Good night.
Bye-bye.